All right, Dr. Bradley, are you ready to take it away?
Can you hear me okay, Shelley?
Yes, ma'am.
All right, thank you. It looks like we've got a few more people logging on. Why don't we just give it till 9:02 just to give people ample time to join us, and then we'll do roll call.
All right.
All right, good morning, everyone. I will go ahead and call to order at 9:02. Just a couple housekeeping items before we do roll call here. A reminder that everything that is part of this meeting is recorded, so if you could please try to keep yourself on mute. If you're joining by phone, to unmute yourself, it's *6. If you're in the meeting electronically, you can just use the mute button on there. Again, a reminder, everything is being recorded. It looks like we have one open mic right now, so just please keep yourself muted if possible, and we will go ahead and move to roll call. Thank you, Kelly.
All right, good morning, everyone. Andrew Tang.
Here.
Anthony Griffey, Tony Griffey. Brent Burgett.
Present.
Chris DeChina.
Present.
Chris Salvino. Clifford Jones. Cliff Jones. Might need to hit *6. I see him trying to get on. David Machika.
Cliff Jones here.
Thank you, Cliff. Debbie Johnston.
Present.
Franco Castramarin. Gail Bradley.
Present.
Garth Gamer.
Present.
Herman Butler. Lyman Pfizer Fund.
I'm present.
Thank you. Judy Baum.
Present.
Melissa Anderson. Neil Williamson. Nirav Patel. Phil Johnson.
Here. Here.
Rod Reed. Sandy Nygaard.
Present.
Sharon McDonough.
Good morning. I'm here.
Good morning. Sean Bowker.
Present.
Tara Johnson. Vicki Bennett.
Present.
All right. We do have quorum.
Thank you,
Thank you,
Shelley.
Shelley. I know that there's been some issues getting off mute, so if anyone is not sure if we captured your attendance, you can either message Shelley or email her directly as well. The attendance report is in your packet. Just a friendly reminder that if you miss 2 or more meetings, we will contact you to see if you still would like to participate in the committee. Currently at this time, we do not have any vacancies. We just wanted to make a few announcements about some ongoing initiatives. Once again, we are still actively trying to push out messaging regarding the naloxone Leave Behind program. As we have seen with COVID, kind of throughout Arizona as well as nationally, there has been an increase in the number of opioid overdoses and deaths. And so we are really trying to increase the opportunity that we have naloxone out there for the community. If you go to the main Bureau website, one of these squares at the bottom that you can click on is for naloxone. We have resources for naloxone Leave Behind, including a training PowerPoint, where to actually order free naloxone for your agency, as well as other resources. So if you have any questions, you can email me directly, or you could go to that section of our website. Next on the agenda, just a reminder, the National Association of EMS Officials has the draft version of the Model EMS Clinical Guidelines. These are open for public comment. There is a survey that is hyperlinked in the agenda, so if you'd like to review those and provide any feedback to that committee, please feel free. We have been working on those for the past just under a year, and those are scheduled to get finalized in the next week or so. So again, just a reminder, if you would like to have input in any sections of that, there is a link on the agenda for that. Next, I'm going to turn over to Chief Garcia for the Bureau report.
All right. Good morning, Dr. Bradley and members of the board. I'd like to start this morning by sharing some general updates from the Bureau of EMS and Trauma System Administrative Team. We'll also share some updates on trends we're observing within Arizona's healthcare and EMS system during the current Omicron surge. On the administrative front, the Bureau of EMS and the 4 regional councils recognize the continued stress put on a finite number of frontline workers. Together, the Bureau and regional councils have developed a workforce needs and interests assessment. Each region will be promoting this survey, and we ask that the statutory committees also encourage participation so we can gain more insight into statewide and regional workforce needs. We know our people in our workforce are our most precious resource. Please take a few minutes to complete the confidential survey, and don't forget to thank our frontline workers, of course. We don't have any updates on air or ground ambulance rules at this time. However, the Article 9 work group will convene again in February to provide additional feedback on CON rules, including response times. Arizona EMCP scope of practice and drug tables were recently updated in August 2021 based on national standards and recommendations from the Medical Direction Commission on EMCPs working in hospital settings. Today, MDC will review EMCP scope of practice again and provide recommendations to the department. This process may require exempt rulemaking and will keep stakeholders up to date on MDC recommendations, next steps, and timelines, of course. For now, guidance on EMCPs working in hospital settings is outlined in a substantive policy statement from the department, and that includes scope of practice and other requirements. Regarding some of the current trends we're observing right now, we continue to see a high volume of positive COVID cases. And although hospitalizations are not increasing at the same rate as our cases, we know that EDs are saturated and the number of staffed beds in hospitals remains extremely limited. We recognize that facilities have activated crisis standards of care based on staffing levels, and the Surge Line Staffing Initiative is currently in place still. As we navigate ongoing challenges that span the healthcare and EMS system, the Bureau would like to lean on statutory committees to help provide recommendations and guidance on strategies for surge that can be applied statewide. We'd also like to focus on some bright spots and highlight best practices. We've most recently observed that in the southern region, hospital and EMS providers have come together collaboratively to address transfer of care and reduce hospital wait times within our system. We continue to be impressed by some of these collaborative approaches that we see throughout the state, and we hope to, again, highlight those best practices during these meetings. The Bureau remains committed to providing timely updates to EMS and trauma providers. through regional council contacts and our Gov Delivery listserv as we move along. If you have not done so already, we encourage you to please subscribe to our Gov Delivery updates from the Bureau of EMS and Trauma System. That, again, is one of the primary methods of communication we'll be using moving forward. That should wrap up the majority of the updates I will provide. The next item on our agenda is welcoming our new Bureau staff. We have been very busy recruiting and hiring new folks. I'm not sure that all of them are able to join us on the line this morning, but we would like to give a shout out to Antonia Gerard. She is the new rate analyst in the CON and rates program. Welcome, Antonia. We've also been joined in the last few months by TJ McKay, our new training program manager, as well as Cody Curl, who is working on our EMS Workforce Initiatives grant. She is our new program coordinator. So thank you to you three as our newest members of the Bureau of EMS and Trauma team. And I will now pass it on to Dr. Bradley and Voxel for the next update.
All right, thank you, Chief Garcia. Just as an FYI, I did mute some open phone lines that were still unmuted. So if you want to speak at any point and you're on a telephone, you will need to press *6 to unmute yourself. Today, we have been doing at each of these meetings some updates regarding opioid and out-of-hospital cardiac arrest data and presenting that data in some bar graph format. Today, we're just going to give a general overview that it does look like those trends are increasing once again, but we do want to do a little deeper dive into that data to ensure that there aren't any data entry issues. So we will give another update on that at the next upcoming meeting. But it does look like that trend that had started in 2020 with increasing in both entities has continued. Next, I'll move on to just an update again regarding the SHARE program, especially at this meeting. Many attendees at this meeting also kind of oversee some of the pre-hospital activities, including the SHARE program for your institution. We have really been trying to kind of reorganize a lot of the documents that go along with that program. What we have done in the past 6 months, or I should say Julia Vinton, has been reaching out to each facility that is a cardiac receiving or cardiac referral center. And we're asking for the facilities to submit documentation that they would like to participate in the program and that they still meet the standards in place to maintain that level of care for the facility. Part of the rationale for that is when this program started, I think almost 14 or 15 years ago, at that time, facilities did need to submit that documentation. Since that time, the Bureau has had quite a bit of turnover, and really that documentation and level of care has never been reconfirmed. And so we want to make sure that EMS providers, if they are going to potentially bypass one facility to go to a cardiac receiving center, that facility that is the cardiac receiving center still meets those standards. We are also working actively within ADHS and the informatics team to work on a long-term solution to hopefully help automate some of the data collection because we said has been a barrier for some facilities as well. The SHARE program really has been instrumental. When you look at things that have been put into place in other states, really they use Arizona as the benchmark of how a system of care has improved out-of-hospital cardiac arrest survival. And so we really are looking to re-energize that program to help increase survival from out-of-hospital cardiac arrest. Lastly, for the Bureau report, there is a link on your packet for a training curriculum that was approved by the Education Committee in November. This curriculum looks at COVID-19 trends, medical decision-making capacity, and patient refusal training. Thank you, Shelley, for displaying that there. This is available in a PowerPoint format, but also we are very fortunate that Dr. Rice, the chair of the committee, has also recorded a version of that, and that is uploaded here as well. I've heard from some entities that the format that is YouTube, they can't download into their training software. So please reach out to us. If you need us to send it to you in a Google Drive format, we can do that as well. But that training curriculum is excellent. It's just under 30 minutes, and I think will provide excellent training for your providers. That is it from my report. We will move along to the standing committee reports. First for TEPI, Sean, do you have a report to give?
I do. Good morning. TEPI met in November, and we welcomed a new member to the committee, and also we announced we still have a vacancy for the air ambulance EMS Premier EMS Agency Quality Improvement Officer. And during the meeting, we introduced new bureau staff, and Vatzel did a great presentation on Arizona system snapshots with trauma and EMS. We approved the minutes, and we announced that we're looking for a vice chair of the committee. Any member of the committee can be a vice chair. We could nominate someone or nominate ourselves, but so far, no interest. The only real discussion item on that committee was a list of potential discretionary reports, and Rebecca Harrow suggested an additional report for use of sedation and restraints to be added, and there was a little discussion on that. We decided to add it and make it number 2 on the agenda, or number 2 on the list of reports. The meeting was then completed, and we said the next meeting will be March 17th. And that's it for Tepi. Thank you.
Thank you, Sean. Next up, Sandy for education.
Yes, Education Committee also met on November the 18th, and our minutes for the previous meeting in July were approved. We also discussed, amended and approved the draft curriculum for the COVID-19 that Dr. Bradley just talked about, the training module, which I agree is really very good. We also discussed and approved the STR for EPI-IM training. It includes a skill sheet and an exam. This was actually approved prior to at MDC in September of 2018, but it was kind of on hold for an update of the scope of practice. So that was passed at approved at this time. We also discussed and approved the STR for EMT capnography with some discussion. This again was approved back in 2018 and was on hold for updates for the scope of practice. So that did go through. There was one on, hold on, I'm looking at my notes. Okay, PACES, the pediatric naloxone training PowerPoint was tabled until further review by PACES, which will be coming up. And we did approve a request for a maternal maternal resuscitation, and a work group will be formed for that. And I think I have covered most of that. Thank you, Dr. Bradley.
All right, thank you very much, Sandy. Next up, Dr. Kasmarin. I don't know if I see him on the meeting for a PMD update.
I can read off the draft minutes if needed.
Maybe just a brief summary, if you don't mind, Shelley, that would be great.
All right. Looking at their November meeting, the minutes were approved. There were 6 draft drug profiles approved for Table 2 agents eligible for administration during a hazardous material incident. Also, there were guidelines approved as amended. There were T3Gs for hydrocarbon and methemoglobinemia. Oh God, sorry. And then the motion was approved to remove drug names from Table 2 that were already listed on Table 1. They also requested to adjust the title, but we have to speak to the Administrative Counsel's office on that. And that's it.
Thank you, Shelley. Next up, Kara for Trauma Managers Workgroup update.
Hi, good morning, everyone. So we did meet last at the end of the year last year. We have an upcoming meeting in February to discuss a new toolbox that we're putting together for trauma program managers. This toolbox will basically be a Dropbox with an area where trauma program managers can go and download resources that other institutions are utilizing for all the things that we asked for, charting, finances, that kind of stuff. So we are actively working on that, and no other updates to give.
Thank you very much. And next up is Adam on the line for a PACES update.
Hello, hi Gail. Good morning.
Hello.
Absolutely. So we are still searching for a council member, specifically a nurse with pediatric experience to help us out. Sandy mentioned that we had tabled the naloxone training tool until the very next meeting, which is on March 17th, I think. We also compiled and reviewed resources for the behavioral health work group. And we are looking for someone with a behavioral health background to sit in on those meetings and lend us some insight. And we'd appreciate that. And then in the last meeting, we've also approved the creation of a work group that will attempt to identify training gap topics for EMS personnel. And that's all I got. Thanks.
Thank you very much. All right, next for discussion and action items. If I can get a motion to discuss, amend, and approve the STAD meeting minutes from September 16th, 2021.
So moved.
Second.
Thank you. All right, and sorry, I did not say, if we can just, for the record, since we are all meeting virtually, if you can just say your name when you make a motion or a second.
The motion was made by Sean Bowker.
Thank you.
Second. Gamer.
And I believe, thank you, Dr. Gamer. All right. All right, the minutes are being projected right now. They are also in your virtual packet as well, if you'd like to review those. Are there any recommended amendments to the minutes? All right, hearing none. Any opposed to the meeting minutes as presented, please say nay. Hearing none. Any abstentions? All those in favor, please say aye.
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 All right, thank you. Next up, we are going to have a discussion by Noreen Adlin regarding state designation and ACS trauma center verification. I think Shelley's got a presentation she will project with this, and I will turn it over to Noreen.
Good morning, everyone. Thank you for giving me this opportunity. Shelley, can you hop onto the next slide? This month is our 4th anniversary of the new rules, which means that now every trauma center has gone through the 2018 rules. And we just, we have a lot of new faces in our group. We just wanted to update what we're seeing and kind of, for the new faces, actually kind of go over the Arizona Statutory Authority. For my EMS colleagues, trauma center in Arizona means a trauma center that's designated by the department. So the Department of Health has the authority alone to say if you're a trauma center, then you have to be designated by the department. Now I'm losing my voice. So these are the definitions in statute. A national verification organization means the American College of Surgeons, but is not limited to the American College of Surgeons. Right now, there are no other verification agencies nationally. So what we see is that a hospital applies to the department for designation, and level 1s and 2s use the ACS as a verification organization. So we have our state standards, and the national verification has their own standards, and we accept those standards. So if you submit an application based on verification, you can just say, here's my national verification at the level that I'm seeking, and your designation is just approved. There's also a state standards. Every level has a state standard, and that's a state standalone process. Shelley, can we go on to the next slide? And as far as this group is concerned, this group does have statutory authority. They can make recommendations on the designation process. They can assist us with the development and implementation of the EMS system as it relates to trauma centers and trauma system plans. We they, with the different groups, you can, this group is responsible for performance improvement and quality assurance, including the state registry. And as you all know, a report has to be submitted to the director every year by October 1st. And you'll see that, you'll see that we send you the STAB report every year, and then has the authority to the chair, which is Dr. Bradley, can assign a subcommittee to point would help us with these initiatives. And you may, for the folks that have been on this group for a while, we did use this when we were looking at how hospitals can meet the child maltreatment criteria that was new in rules. So the group got together and said, okay, so now that we require this, how does the hospital demonstrate that they're meeting these requirements? Next slide. So I went over the different designation pathways, and one of the things that I wanted to stress is that there are two separate pathways. Trauma center verification is based on the ACS standards, whereas the trauma designation pathway is based on Arizona standards. And we look at things a little bit differently. With the American College of Surgeons, it's primarily a peer review where you have surgeons and trauma nurses reviewing surgical care, where they're actually digging into the medical records and making sure that the care was appropriate and timely according to the ACS standards. On the trauma center designation pathway for the state, the hospital, we look at, does the hospital have the resources, capability to provide the level of care that they're seeking, and have those resources, have they been allocated? So what we're looking for policies and procedures and implementation of those policies. Shelley, can we move to the next one? Thank you. So with these, we call them new rules. It's been 2018, so they're not really new anymore. One of the things that we're seeing is with the state pathway, if a hospital chooses to use the American College of Surgeons as their pathway, it's a standalone pathway. If we're not invited to attend and there's issues or something happens, we cannot help the hospital. When the hospital uses the American College of Surgeons pathway, because there's two separate applications. There's an application based on meeting state standards, and there's application for verification. And this was something that our hospital colleagues wanted, because the application based on state standards is a very long application. And so is the American College of Surgeons application process very long. They use what they call a pre-review questionnaire, and they submit that to the college. With our state pathway, we do something very similar. The only thing is that the questionnaire that the college uses is for us the application. So our application for trauma designation is about 34 pages long. It requires a lot of attachments, policies to be submitted with the application. So what we see is that it's particularly our level 1s, 2s, and 3s. They don't want to do both of them, and it's understandable. The downside to that is that if they don't apply a meeting based on the state standards, if something happens with their ACS and they're not verified, we have no process in place to be able to help them with a corrective action plan or issue a designation. They lose their designation. And if we could, so it's I can't stress too much that really hospitals need to consider this. They have to invite us to attend. What they can do is invite us to attend their ACS review. Actually, there is one going on now that Kim is at, and they're all virtual. So we kind of pop in and attend and answer questions on behalf of the state. So, we try as much as we can to keep our hospitals designated. But like I said, our hands are tied if the hospitals take the state path, the ACS pathway, and there's no state staff in attendance at those site surveys to verify state standards. And if we can move to the next one. So for the level 1 and 2 state pathway, they have to apply to ACS for verification because the level 1 and 2 pathway requires an assessment by ACS. So they're still involved. And what we typically do is we attend the site survey with the ACS reviewers on behalf of the state. So they have to apply for ACS. They have to inform us 30 days prior to their ACS site survey that and invite us to be on the premises. And now being on the premises, it's all virtual. So we attend virtually with the ACS reviewers. And they have to invite us to review the facility, document the capabilities of the healthcare institution during the ACS assessment. The department will then send a written report within 30 days of our findings. And, if necessary, we will, give the opportunity for the healthcare institution to provide a corrective action plan if one is necessary. And throughout our rules, this is language that is directly from the rules. The reason why that we use the term healthcare institution is not all trauma centers have to be a hospital. Our level 4s can be standalone ED facilities or outpatient treatment facilities, but they have to meet trauma center requirements for a level 4. Moving forward. Next slide. So when a hospital is designated, whether they're whether they're their state pathway or whether they're ACS pathway, they need to submit a state designation renewal application at least 60 days before they expire and no more than 90 days prior to their designation expiration date. Once a hospital, this is really key. Once a hospital has submitted their application for designation, their designation stays intact in that it does not expire until the department has made a determination. So if you ever go onto our website, and you look at the trauma center, the list, you will see that we have highlighted in blue. It may appear that a hospital has expired, but when it's highlighted in blue, that means that there is an application pending, and the hospital is considered a designated trauma center. It just means that our process takes a little bit of time, especially with the American College of Surgeons, and a lot of it is waiting for their reports and their paperwork to come back to us. Next slide. So when we look at the different levels, this is just like a highlight of the difference in the clinical capabilities. It's not the complete list. So, the state required, we're talking state pathway here. With level 1, ACS is pretty similar, actually almost the same for ACS, but a trauma surgeon has to be in-house and available at the patient's bedside within 15 minutes. And the trauma centers have to track this, and I have to say from someone that's on these review processes, they're very good at actually being there. Most of the hospitals, their trauma surgeons at the patient's bedside is in the 90 to 95 percentile or even higher. So they also have the following, have to have the specialist on call and available at the bedside. For ACS, it's 30 minutes. For the state, it's 45. So they have to have a neurosurgeon. They have to have critical care medicine, hand surgeon, thoracic surgery, cardiac surgeon, orthopedic surgeons, radiologists, ophthalmology surgeon, plastic surgeon, and OBGYN. And this for the state standard, it's 45 minutes once they're called. The different from the American College of Surgeons, the state does not allow these specialists to be on call at any other facility at the same time. With the American College of Surgeons, they can be on backup call, but they have to review that and track that through their PI process to make sure that the care is timely and the surgeons are there, the specialists are there when they need it. So that's a little bit different between the ACS and the state pathway. Also, the state pathway requires that there's a volume of 1,200 trauma admissions per year. They have to have a research program, an outreach program, an education, and they have to include a physician residency. There's a little bit, there's the differences with there's differences with ACS on this issue, this criteria. I think with ACS, you know, and I don't want to speak for ACS because I certainly don't know their criteria as well as I know ours. But one of the differences is that ACS requires a certain amount of publications in peer journals. As far as physician residency, we really, you know, allow emergency medicine, whereas the American College of Surgeons residency program is surgical residency only, and their residency program is quite a bit more defined. Shelley, can we move forward? Thank you. I skipped level 2 because we don't have any level 2s in Arizona, and that's typically because the funding associated with our level 1 trauma centers is only for level 1 trauma centers. So there's really no incentive for a hospital to become a level 2 trauma center. The clinical capabilities are the same. They just don't have to have the research, the volume requirement, or the residency program. So all of our hospitals have decided, you know, that you know, to go for the funding. And, you know, so maybe we'll have level 2s, but it's not likely anytime soon, as we have no applications pending at this point. So level 3 trauma centers. A level 3 trauma center has to have emergency medicine trained physicians. They have to be equipped to provide advanced trauma life support and be able to resuscitate patients 24/7. And that's patients of all ages. So every trauma center in Arizona is required to be able to resuscitate patients of all ages. Now, having said that, they don't have to admit them. You know, we see hospitals from time to time say, well, we're not a pediatric trauma center, so don't bring pediatric patients there. They are required to resuscitate them, but for my, you know, EMS colleagues, if you have a level 1 trauma center or any level 1 trauma center, and you think you can safely get those patients to the pediatric trauma center, that is definitely preferred. You know, if you have an unstable patient and that needs to be resuscitated, then you need to go to the nearest trauma center, and that again, follow your regional guidelines. That's all according to what your medical director you know, prefers. And, you know, but this is the state's position on that. You know, level 3 trauma centers are required to have general surgeon available at the patient's bedside within 30 minutes. They don't have to be in-house. And the hospitals track this as well. They have to have orthopedic surgery 24/7 available at the patient's bedside within 45 minutes. Again, they don't have to be in-house. And they have to have policies in place that ensure that an operating room and teams are available as needed. So this, you know, we do have some level 3 trauma centers in the central region. Typically, you know, what we see on the EMS side of it, that if you have an isolated injury that's a trauma, you know, our level 3 trauma centers are capable of you know, treating those patients. And again, if you have an unstable patient, or if you think a patient needs to have be at a you know, a level 1 trauma center, that's always the best option. And then to level 4, the next slide, please. Level 4s, you know, when I spoke that they don't have to be hospitals, and typically we see level 4s in very rural areas, and what we're looking for is that the hospital be able to resuscitate, have equipment, and have trained staff in order to, and the focus with our rural level 4s is really transfer these patients out quickly. Yeah. And for, all trauma centers have to have a trauma manager. For level 4, all the upper levels have to have a medical director. Level 4 trauma centers don't have to have a medical director. And what we see in very rural hospitals, particularly here in Arizona, is that some hospitals do not have physicians in 24/7 in these hospitals. The care is provided by nurse practitioners and PAs. Now, having said that, the first time I was aware of this was a hospital in a very remote area, and these mid-level providers, they did an excellent job of treating these patients and getting them out quickly. The patients were by far, were transported to these hospitals. Most of these patients would come in by POV. They would be, they had these patients out within 45 minutes. So, and that's what we're looking for with a level 4, the clinical capabilities. Every trauma center, including a level 4, they have to have a trauma team. It has to have defined roles and responsibility, and they have to have the equipment necessary to resuscitate patients of all ages. And when we talk about the training, we're talking about ATLS providers, physicians that are ATLS trained, or they are actually certified in ATLS. They're also required to have, for the mid-level providers, they're required to be current in ATLS. They also have to have a rapid infusion capabilities for blood and crystal oil, and be able to provide trauma, thermal control, radiology services, laboratory services, and every hospital in Arizona now is required to have child maltreatment assessment capabilities. The next slide, please. I know I'm there's a lot with this, and I'm trying not to take up the group's time too long. I can, those of you that know me know that I can go on for hours. So I think I review, basically for trauma center requirements at all levels. They have to have a trauma program manager, they have a trauma team, they have to submit trauma data to the registry. Level 4 is do a reduced set. They have to have a trauma performance improvement process. They have to participate in injury prevention programs. They have to also participate in state and local regional trauma-related activity. And they have a set of audit filters that they have to monitor. For my EMS colleagues, you may see trauma centers really pushing, to get their patients out, particularly level 4. If a patient is at a level 4 trauma center and it's a trauma patient that needs surgical capabilities, these hospitals don't have that. So what it's almost like treating a level 4 in rural areas, as almost like a 911 call, although they're not allowed to call 911. Now, that's not to say that level 4 trauma centers don't have the other clinical capabilities. It's just that we don't require them to have them 24/7. So we do have quite a few high functioning level 4s that are capable of resuscitating, not only resuscitating, but admitting patients, and they have the clinical capabilities provide OR services. So just to say that this is the minimum requirement. We have many trauma centers that far exceed that requirements, these requirements. And it's up to your medical director as far as where these patients what patients can be taken there. Next slide. Any questions?
Noreen?
Sure.
Oh, Noreen,
Yeah.
I've got a question. This is Garth Gamer. So during the pandemic, did the ACS get behind with their verification process? And if they did, how far behind did they get? And did they catch up?
Well, Dr. Gamer, what they did for what they paused. They took a year off, and for the hospitals that were the centers that were designated based on their ACS verification, they just extended their verification for a year. They just gave them the year, an extra year, added it onto it. We couldn't do that on the state pathway centers because they're not designated based on the state pathway. So we had no way in rule. So what we're looking at now is we're looking at some of our level 1s and 3s that just got the extension, and those that were state pathway, they had to have ACS come out early. So what ACS is doing now, all of their site surveys are now virtual. Like I said, Kim and I are in one now. I'll hop back into there after this presentation. And so what they're doing, it's, and I don't want to speak for ACS. I think that, we have representatives from ACS on staff, but from what my understanding is that they will start resuming in-person site surveys, I think in March, and they will, so there's somewhat of a backlog for that, but right now they're all virtual. And to be honest with you, the virtual reviews are pretty neat. We're able to they do a tour. They put a camera on a wheeler through the hospital and interview staff. So it's quite an interesting process. So to answer your question, they just granted an extension.
Thank you for all that information. Great work.
Vicki, you have your hand up.
Yeah, I was just going to clarify that the latest from the American College of Surgeons is that they plan to continue the virtual visits. At some point in the future, it may become more of a hybrid model so that certain types of visits, whether that's a focus visit or a first-time visit, might be on site, or certain members of the team might be on site. But the plan is for the immediate future for them to continue with the virtual visits. They are a lot of visits because we did have a year extension, so they are doing a lot of visits currently. It's a very busy time, but they are doing well. They're on schedule, and I'd be happy to answer any other questions if there are any from what I know. But I just wanted to let you know that they do plan to continue the virtual component.
Thanks, Vicki. And Vicki brings up brings up virtual the focus visits. We do that as well. When the state comes in, when our surveyors come in, and we use a level 1 trauma surgeon and a level 1 trauma nurse manager as our review team, along with bureau staff. And if the hospital has any criteria deficiencies on the state side, then we will issue a 1-year designation and request a corrective action plan from them. So basically, we do have some centers now that, that'll apply, they'll get 1 year, they submit the corrective action plan. Once the year is over, we review they submit a shorter version, which is really the application and an update on their corrective action. American College of Surgeons does pretty much the same thing. We stole it from them. It's what we were seeing is with our continuous 3-year designation, we would give hospitals, they would submit a corrective action plan, then we had nothing in rule that allowed us to follow through with the corrective action plan and ensure that they're in compliance. Now we have that. So we're very busy on the trauma side, meaning that sometimes we have hospitals that are renewing, sooner than 3 years. So it's just a little bit more work, but it's worth it. Sandy, you had your hand up?
Yes, Noreen. I'm assuming that this presentation, which is really good, will be available on the website for information.
I think that we probably could. And if there are any questions, we're continuously looking at ways to provide more information. And like I said, this is our we're now 4 years into the new rules, so now we're kind of digging in and saying, okay, now that the rules are complicated because it's a complicated process. We have a lot of what ifs addressed in the rules, and the main point that we wanted to stress with our trauma centers is really be careful which pathway you take. Reach out to the bureau and see what you think and discuss with us what you think the best pathway is, because we're here to help you. We don't like to be put into a position where we can't help you. And that's really unfortunate. And one of the things that we found in the rules that we have now, that there's absolutely, we're completely limited when it comes to hospitals that choose the ACS pathway alone. So
Thank you.
I think that's all I have. If anybody else has any more questions,
Thank you, Noreen. That was an excellent presentation. And, I think just to reiterate Noreen's point, we recognize that hospitals have been strained with the onset of COVID, and service lines have been stretched thin. And some of those things are starting to manifest themselves in terms of capabilities. And definitely we would like to maintain our trauma system here in Arizona. So I think one of the things that we're seeing more recently in some of the ACS site visits is that there have been some deficiencies due to some of the strain on the system. And so having the backup of the state pathway, if it does not go the way a facility wants with ACS, we really want to make sure we have that available. So if you have any questions, Noreen and Kim are excellent resources. They can help guide you through the process, but we really felt like this was an important topic for this committee to discuss. Any further questions or comments regarding that before we move on the agenda?
Yeah, this is Dr. Phil Johnson. Noreen, thank you for a great presentation. I just want to point out what a difficult time this has been as an ER physician in a rural area. And I will have to say thank you to the level ones for not letting the COVID issues stand in the way of real trauma. And those are the patients that can get out in good time. It's the other ones that have taken forever. I've sat on non-STEMIs for up a week. I've had 3 ventilators running in my ER for 3 to 5 days. I've taken care of ICU patients for a long, long time trying to get them out. But level 1 trauma patients, I'm getting out, and we're saving lives that way. And I just want to really thank the level 1 trauma centers for all they're doing. I know it's hard.
Thank you for that feedback. Always good to hear the positives. All right. If there's no further questions, I believe that Dr. Patel was next on the agenda. I know he is traveling out of state for work. I'm not sure, Dr. Patel, if you're on the line yet. We will move on and see if he's able to join us before the meeting ends. I just wanted to make a mention at this committee that ACS has I think, close to final version of the field triage updates that should be coming out sometime in the next couple months. Those were last updated over a decade ago, so this is going to be a substantial change. I know Arizona did a really nice job the last time the updates came up of really trying to push this messaging out statewide, and STAB was an important component of that. So as we get that final version from ACS and that does get distributed, we will make sure that this comes to STAB and that we also help distribute that to all 4 regional councils and EMS providers. So just wanted to make mention of that. I don't know if anyone has been a part of that process or has seen that. I know that they did take stakeholder feedback when they asked for a review on kind of the current version of the field triage guidelines. Any comments or input from anyone who has seen the new version or participated in the stakeholder feedback? All right. Next on the agenda, we have the standing item, which is discuss future STAB projects and agenda items. We last had a research presentation. We've had a couple of nice presentations. We had EPIC. We also had a blood product presentation by Dr. Dabrowski as well. Is there anyone that you don't have to necessarily tell us now, but if you have been doing some type of trauma research at your facility and you'd like to do a 5 to 10 minute report at the next STAB meeting, so far those presentations have been really helpful and I think well received by the committee. So we want to make sure we continue to advertise that. So again, I think the big one we'd like to see would be the research discussion. If anyone has some trauma research involving EMS that they would like to present at the next meeting, you can email Shelley or myself, and we'll make sure we look at that for the agenda. Next, any agenda items to be considered for the next meeting, please, you can speak up now, or again, I'll let Shelley or myself know. Call to the public. All right, the summary of current events is in your packet. So again, that is available virtually. You can click on any of those links. Our next meeting will be May 19th, 2022 at 9 o'clock. We will determine at that close to that time if we will be a hybrid or fully virtual model again. If there's nothing further, we will go ahead and adjourn at 9:56. Thank you, everyone.